Good afternoon and welcome to today's call, Vaccinating the Immunocompromised. Your host today is Erica. Erica, please go ahead.
Good afternoon and welcome to today's webinar presented by Lake Superior Quality Innovation Network. Lake Superior QUIN is comprised of three organizations, MPRO in Michigan, Medistar in Wisconsin, and Stratus Health in Minnesota, to support the Centers for Medicare and Medicaid Services, priorities for healthcare quality improvement in each organization's respective state. I would like to introduce you to today's speaker. We have Heidi Loynes, Immunization Nurse Educator with the Division of Immunization at the Michigan Department of Health and Human Services. At this time, I would like to turn it over to Heidi.
Thank you, Erica. I would like to thank everyone for having the Michigan Department of Health and Human Services present today. I am Heidi Loynes. I'm one of the nurse educators with the state of Michigan, and I will be talking about vaccines in the immunocompromised adults. I first want to ask, so please forgive me for, I do have a cold, so I'm trying to work my way through that. I may take a break to get a drink every once in a while as well. This topic of immunocompromised adults is very detailed, and I'm only going to be giving a very brief overview of all of it and some key points. The main point you will hear throughout this presentation is that we need to always assess for the needed vaccines throughout the lifespan, and we need to strongly recommend our patients receive the vaccine, especially our immunocompromised patients. These are the objectives that we will cover today. We are going to be identifying two reasons why it's important to protect the immunocompromised population. We'll be discussing recommended vaccines for the immunocompromised adult and listing two strategies to vaccinate the immunocompromised population. Here is a brief overview of the presentation today. We are going to be discussing that vaccine-preventable diseases still exist. Some strategies for vaccination. We will define altered immunocompetence, go over some general principles when dealing with an altered immunocompetent person. We will then look at some key points on live and inactivated vaccines. And lastly, we'll cover some special topics on certain vaccines that are recommended for the immunocompromised adult and then vaccinating for certain medical indications. We know that vaccine-preventable diseases are still out there. As you will see in the next slide, we still have cases in Michigan that occur. These diseases are hard enough on the person who is immunocompetent, which is a person who has the ability to produce a normal immune response following exposure to an antigen. When these diseases hit persons who are immunosuppressed, their immune system struggles to fight off the antigen. These diseases are much worse for them, and the increase in hospitalizations and even death is greater in a person who is immunocompromised. Here is some data specific to Michigan. It can be found at the MDHHS website at www.michigan.gov/immunize. The document Summary of Vaccine-Preventable Diseases reported to the Michigan Department of Health and Human Services is a report that details out the cases of vaccine-preventable diseases for 2014 and compares the diseases to previous years. As you can see, we still have VPDs occurring in Michigan. And as you know, we have had even larger outbreaks nationwide. For example, the California Disneyland measles outbreak. VPDs are harmful to patients who are immunocompromised, and the easiest way to protect our vulnerable population is to vaccinate them with the appropriate vaccines and vaccinate those around them to help provide another layer of protection. Vaccines are not just for children. Adults need to be vaccinated as well. Vaccines are an important step in protecting adults against serious, sometimes deadly diseases. People with compromised immune systems, such as those with cancer, HIV infection, and Crohn's disease, are especially vulnerable to illness, and most should receive the flu shot and other vaccinations. People with chronic medical conditions are more likely to develop complications from certain vaccine-preventable diseases because their immune system is already under stress. Some of these serious complications can be long-term illness, hospitalization, and even death. Ensuring that our patients are protected is a top priority. One of the strongest predictors of receiving vaccination is a strong provider recommendation. It is the number one strategy to help ensure your patients receive their vaccines. The reason why a strong provider recommendation has been shown to work is because your patients value your advice. You want to ensure patients and parents hear your endorsement of vaccines. Remember, your recommendation is the strongest predictor of whether or not someone will be vaccinated. Your immunocompromised patients may be nervous about vaccines. However, education and a strong recommendation is the best strategy to ensure your patient receives all the recommended vaccines. Another strategy to ensure your patients receive their vaccines is to know the recommendations and administer all the needed vaccines. Over the next 2 slides, we are going to review the recommended immunization schedules for adults. These schedules are updated every year and come out at the end of January and the first part of February. The schedules are a great resource to help ensure your patient receives all the recommended vaccines. The footnotes contain a wealth of information and should be read to ensure vaccines are given based on the recommendations. The footnotes also contain information on which vaccines are recommended based on medical indication and how many doses are necessary. Here is the first schedule. This schedule is similar to the childhood schedule, where the age ranges are at the top and the vaccines are on the side. This schedule is a good overview of vaccines to consider for the adults based on their age. But as you know, other factors go into determining an adult's vaccine needs. Adults need to be assessed by using HALO. This is where you look at their health status, age, lifestyle, and occupational risk as we are assessing for needed vaccines. This is where the next adult schedule is helpful. Here is the other schedule. This schedule is unique because it is based on medical indication. So the medical indication is on the top and the vaccines are along the side. This schedule is great when you are dealing with patients who have high-risk conditions such as diabetes mellitus, chronic heart disease, immunocompromising indications, and etc. The schedule shows what vaccines they can receive and what is contraindicated. As you can see, the vaccines in red are contraindicated. If you look at the immunocompromising conditions column, you will see that MMR, varicella, and zoster are contraindicated. The footnotes are essential to understanding the recommendations and ensuring your patient that is immunocompromised is vaccinated. We will now start our discussion about the immunocompromised patient. Vaccines are critical for people with health conditions such as a weakened immune system because their immune system is already being challenged, and we do not want them to be exposed to a wild-type virus such as measles. Vaccines help create an immunity so that our bodies are able to recognize the disease and try to fight it off. Immunocompromised patients are one of the most vulnerable populations, yet they seem to get missed when it comes to vaccines. It could be because they are going from provider to provider for care and everyone thinks the other person is recommending the vaccine. It comes down to a joint responsibility, a shared responsibility for vaccination. Specialists share responsibility with the primary care provider to ensure appropriate vaccines are administered and to ensure that household contacts are vaccinated as well. If the provider does not carry the vaccine, then it is a standard of care to refer the patient to a site that they can receive the vaccine at. So we know that we should be providing a strong recommendation for vaccines, that we should be offering the vaccine, and that if we do not carry the recommended vaccine, then we should refer our patient to a site where they can receive that vaccine. This is becoming more and more important as the number of patients with immunosuppression is increasing. We know that people with compromised immune systems are more vulnerable to illness, yet our rates tend to be lower in patients with compromised immune systems. This can be for a variety of reasons, but one reason is we as healthcare providers may be concerned about safety and effectiveness of the vaccine for the immunocompromised patient. So this is what we know. We know we have a lot of work to do. The Healthy People 2020 goal is to have vaccination rates for adults 65 years and older for pneumococcal vaccine at 90%. As you can see, our adult cancer patients reported that only 48.3% received their pneumococcal vaccine. and only 57.8% received a flu vaccine. So as you can see, we do have work to do. Our most vulnerable population is going unprotected, even when we have guidelines and recommendations to vaccinate this population. Here are two great resources that provide information for vaccinating the immunocompromised patient. These guidelines were created to provide primary care and specialty clinicians with evidence-based guidelines for active immunization of patients with altered immunocompetence and their household contacts in order to safely prevent vaccine-preventable infections. The 2013 IDSA guideline includes recommendations for most available vaccinations, ranging from hepatitis A, measles, mumps, and rubella, otherwise known as MMR, and other childhood vaccinations, to those for influenza, pneumococcus, and herpes zoster. This guideline covers specific medical indications and breaks down in detail the vaccines needed. Understanding what altered immunocompetence is important, especially when recognizing that your patient may need certain vaccines based on a medical indication. Altered immunocompetence is when the body is not producing a normal immune response following the exposure to an antigen. So the person can become very ill because their body is not able to fight off the disease. Altered immunocompetence is used synonymously with words such as immunosuppression, immunocompromised, and immunodeficiency. Altered immunocompetence can be classified as primary or secondary immunodeficiency. We are now going to review this in the next couple of slides. Primary immunodeficiency is inherited, and it is when there is an absence of deficiency or cellular or humoral components. Some examples of primary immunodeficiency is congenital immunodeficiency and severe combined immunodeficiency. It is up to the provider to determine what type of immunodeficiency the person has and the degree of immunodeficiency that the patient has. This would entail assessing blood work and reviewing tests. Secondary immunodeficiency is generally acquired. It is the loss of cellular or humoral immune components that occur as a result of disease process or its therapy. Some examples of secondary immunodeficiency are HIV, hematopoietic malignancies, treatment with radiation, or with immunosuppressive drugs. Now that we know what altered immunocompetence is and what is primary immunodeficiency and secondary immunodeficiency, we will start our talk about some general principles to vaccinating a person with altered immunocompetence. Here are some general principles for working with the altered immunocompetent person. Because of their altered immunocompetence, certain vaccines are recommended to be received. An activated vaccine should be administered to patients with altered immunocompetence. The benefit of protection received from the vaccine against the disease outweighs the possibility of decreased vaccine effectiveness. Live vaccines should not be recommended or given to the patient with altered immunocompetence. Household contacts should be vaccinated, and it is safe for them to receive inactivated and live vaccines. We are now going to review general rules for live and inactivated vaccines. Here we're going to take a closer look at some general rules for live and inactivated vaccines for the immunocompromised patient. The concern with live vaccines and the person who is immunocompromised is that they could be at risk of transmission of disease due to the state of altered immunocompetence. The secondary concern is that the effectiveness of the vaccine could be reduced. A permanent condition to receiving live vaccines is immunosuppression. You can see this on the recommended immunization schedule for adults based on medical indication. If you remember, those were the bars that were in red. Until the state of immunosuppression changes, live vaccines are contraindicated. There are temporary conditions, such as medication use. Once the temporary condition has resolved and the primary provider assesses the patient as clear, the live vaccine may be administered. It is strongly recommended that the primary care provider or specialist are the ones assessing that the vaccine can be received that day. We know that certain drugs may cause immunosuppression. For instance, persons receiving cancer treatment or radiation therapy should not be given live vaccines. However, as stated on the previous slide, once those temporary conditions are resolved, live vaccines can and should be given when the provider recommends it. Another question that comes up often is vaccinating when a person is on a corticosteroid. Persons receiving large doses of corticosteroids should not receive live vaccines. For example, this would include persons receiving 20 milligrams or more of prednisone daily or 2 or more milligrams per kilogram per day. It is recommended to wait 3 months following the stopping of the high-dose corticosteroids before administering any live vaccines. Another key point to think about is when you're thinking about aerosolized steroids, such as an inhaler for an asthmatic. That is not a contraindication to receive a live vaccine, nor are alternate day, rapidly tapering, in short, less than 14 days, high-dose schedules, and topical formulations of a corticosteroid. In these instances, live vaccines can be received once the primary care provider assesses the patient. Inactivated vaccines are generally safe to administer to a person with a high-risk condition and should be recommended and given. The concern comes back to the degree of altered immunocompetence and the effectiveness of the vaccine when administered to a person who is immunocompromised. This is where provider assessment is vital. Inactivated vaccines can be administered to people who take immunosuppressive drugs or who have a condition that causes them to be immunocompromised. The vaccines might not be as effective as they would be when given to a person with an intact immune system. If possible, the immunosuppressive drug should be discontinued for a month prior to vaccination. Then allow the vaccine 2 to 3 weeks to generate an immune response before restarting the immunosuppressive treatment. But obviously, this is not always possible. As you can see, there is a lot to consider before vaccinating the immunocompromised patient. There are general rules and principles to be mindful of. We know there can be challenges when vaccinating the immunocompromised patient. Even though they receive the vaccine, they may not get the full protective immune response because their immune system is so compromised. As healthcare providers, we should still recommend the inactivated vaccine. However, when we are dealing with the actively immunocompromised individual, live vaccines are contraindicated. This is because of the theoretical increased risk of prolonged shedding and disease from the live organism present in the vaccine. That is why we wait to give live vaccines when the person is in an immunocompromised state. Determining altered immunocompetence is important because incidence or severity of some vaccine-preventable diseases is greater in people with altered immunocompetence. As a result, certain vaccines, such as inactivated influenza vaccine and pneumococcal vaccines, are recommended, specifically for people with altered immunocompetence. Screening for contraindication and precautions for any vaccine is key to vaccine safety. It involves having a physician, PA, NP, or even a registered nurse in the clinical decision-making process to ensure that the person can and should receive that vaccine that day. Screening and assessment provides a layer of protection for the provider. It honestly should be done with every vaccine assessment. Here you can see a screening tool on this slide. This form and others like it can be found at the Immunization Action Coalition website, which is at www.immunize.org. Here is a list of vaccines that we'll be going over in detail over the next few slides. This slide just shows you that certain vaccines are recommended for certain medical indications. This is where going back to the immunization schedule based on medical indication is helpful. As you can see, pneumococcal vaccines are recommended for persons with immunosuppression, asplenia, and renal disease. Meningococcal vaccines are recommended for persons with asplenia and complement component deficiency. All this information and when to provide the doses and intervals to the next dose can be found in the footnotes of the schedule. We will now discuss some of the vaccines that are recommended and that are contraindicated for altered immunocompetent persons. Certain vaccines should be considered when assessing the patient with a medical indication. These vaccines in the red text box, which are pneumococcal vaccine, Hib vaccine, MenACWY vaccine, which is also known as MCV4, Menactra, or Menveo, and then we have MenB vaccine and the flu vaccine are strongly recommended to be received when a person is immunocompromised or has certain medical indications. Hib, pneumococcal, and meningococcal vaccines help provide protection against invasive encapsulated bacteria. When a person is immunocompromised, splenic, or has terminal complement component deficiency, then their body cannot fight off encapsulated bacteria as well, which is why vaccination is important. It is also the standard of care to ensure that our patients are up to date on all their vaccines such as Tdap, DTaP, Hep A, Hep B, IPV, and HPV vaccines. These are the vaccines that we should be assessing for in a person who is immunocompromised or who has a chronic medical condition. We will now take a look at vaccines that are contraindicated in the immunocompromised patient. Here is a list of vaccines that are contraindicated in a person who is actively immunocompromised. All these vaccines are live vaccines. As mentioned earlier, they are contraindicated because of the theoretical increased risk of prolonged shedding and disease from the live organism present in the vaccine. That is why we wait to give live vaccines when the person is in an immunocompromised state. A proper assessment will help determine if these vaccines should be received today. Now we're going to look at some of the recommended vaccines for immunocompromised patients a little closer. Here is just a reminder to utilize the recommended schedule. Again, this is the schedule that is based on medical indications, and it's great to use when assessing the adult based on risk conditions. The medical indications listed on the schedule are pregnancy, immunocompromising conditions, HIV, men who have sex with men, kidney failure, heart and lung disease, splenic, liver disease, and diabetes. What you do is you just take a look at the column that you need to see. So if you're dealing with an immunocompromised patient, and you go straight down that column, and it'll tell you what vaccines are recommended to be received today and what vaccines are contraindicated for that day. And then we assess the patient, we assess their immunization history, and we read the footnotes for further detail to determine what vaccines that patient needs that day. Here is a complete list for whom meningococcal vaccine is recommended. As you can see, the risk groups in the red text box show splenic and persistent terminal complement component deficiency as a risk group for meningococcal disease. Ensuring these risk groups are vaccinated is crucial. We know that disease incidence is at historic lows, but the overall case fatality ratio remains at 10 to 15%, and then 11 to 19% of survivors have long-term sequelae, which could include neurological disability, limb or digit loss, and even hearing loss. This is why ensuring we vaccinate those at highest risk is important. because those long-term outcomes and the case fatality ratio is really high. MIN-ACWY, which again also is known as MCV4, and the reason why I keep saying that is because we just changed over the acronym from meningococcal conjugate vaccine with the 4 after that, so MCV4, over to MIN-ACWY so that everyone would know which serotypes are in the vaccine. That came down straight from CDC. So MIN-ACWY is routinely recommended for adolescents at 11 to 12 years of age and at 16 years of age. The recommendation for MIN-ACWY varies according to the risk group. As you can see, we want to ensure college freshmen living in dorms receive a dose within the last 5 years because they're one of our highest risk groups as well. So for example, persons with certain medical conditions such as asplenia or terminal complement component deficiency would receive 2 doses of MIN-ACWY with a minimum interval of 8 weeks between those doses, and then they're going to receive a booster dose every 5 years. So just knowing that with the intervals and knowing the boosting dose of every 5 years, you can see how it can be difficult to determine when the person with a high-risk condition needs a vaccine like meningococcal vaccine. So that's what this slide is here. It is a great resource that we have that you can use to help you when determining when to give a dose of MIN-ACWY and the interval for the next dose. It does cover vaccine dose recommendation and booster doses for those persons with a high-risk medical indication. We highly recommend you go to the website and pull this handout and use it on a regular basis. It's an excellent handout that provides the recommendations, and it's in an easy one-page format. We would never expect anyone to remember all this detail, so utilize resources such as this. This handout, meningococcal vaccine recommendations by age and risk factors for serogroups A, C, W, or Y protection, can be found at www.immunize.org. MenV vaccine is one of our newest vaccines that we have that has come out in the recent year. MenV is recommended for those persons 10 years of age and older with the risk factors listed on this slide. So as you can see, persistent terminal complement component deficiency and asplenia are on this slide, as well as taking the medication Solaris. Solaris will cause immunosuppression, so that is one of the reasons why we would want to give MenV vaccine. There are 2 MenV vaccines available for use. One is known as Tremenva, and the other is Bexsero. For further information on these vaccines, you can take a closer look at the MD-HHS Quick Look on meningococcal B vaccines. And that quick look can be found at www.michigan.gov/immunize. There are 2 pneumococcal vaccines available. One is PCV13 and the other is PPSV23. As you will see on the next few slides, both of these vaccines have recommendations based on high-risk indications. Note that there may be times based on the medical indication that both vaccines are recommended to be received. If they are both recommended, PCV13 is recommended to be given first because of the immune response to the vaccine when given in this sequence. An evaluation of the immune response after a second pneumococcal vaccine administered 1 year after an initial dose showed that subjects who received PPSV23 as the initial dose had lower antibody response after subsequent administration of a PCV13. So this is the reason for why it is recommended to receive PCV13 as the initial dose, followed by a dose of PPSV23. Now this vaccine is extremely important, and especially when we're vaccinating our immunocompromised patients. And it's important because pneumococcal disease accounts for an estimated 400,000 hospitalizations per year, and the case fatality rate is 5 to 7% higher in the elderly. Ensuring our most vulnerable population is protected through vaccination is essential. PCV13 is routinely recommended at 2 months, 4 months, 6 months, and 12 to 15 months of age. For the best protection, it is important to ensure that we're following the recommended schedule and administering those 4 doses of PCV13 at the recommended ages. PCV13 is only indicated for high-risk persons who have not received a dose of PCV13. For persons 6 years of age and older, if they meet one of the risk criteria in the red text box and have had no previous dose of PCV13, then they are recommended to receive 1 dose of PCV13. Note that there is a routine recommendation for persons aged 65 years and older to receive a dose of PCV13 if they have had no previous dose of PCV13 before. This is where assessing and knowing the patient's medical history and vaccine record is important, because this vaccine here, PCV13, when we're looking at persons 6 years and older, is all based on if they've had a previous dose of PCV13 before. Now here is the second pneumococcal vaccine. This vaccine has been along for a long time. The acronym is PPSV23. It is also known as Pneumovax, or to the public, as most of your patients will call it, the pneumonia vaccine, which we are trying very hard to pull them away from using that verbiage, the pneumonia vaccine, because this vaccine covers a lot more than just pneumonia. So I always want to try to stress that to providers to correct your patient and remind them that this is much more than that. This is a pneumococcal vaccine. This vaccine does have recommendations based on high-risk indications. As you can see on this slide, there may be times that a person with a high-risk indication may receive 1 dose or 2 doses. Those receiving 1 dose are persons aged 2 through 64 years of age that have chronic pulmonary, kidney or heart disease, diabetes mellitus, alcoholism, CSF leaks, or cochlear implants. When a person is recommended to receive 2 doses based on a risk condition, such as immunosuppression caused by disease or medication, HIV, functional or anatomic asplenia, or malignancy, those doses should be separated out by a 5-year interval. So when they need 2 doses, we want to ensure that those 2 doses are separated out by a 5-year interval. Once a person is age 65 years or older, they are routinely recommended to receive 1 final dose of PPSV23, regardless of their medical history. So what this means is, up until 65 years of age, PPSV23 is going to be based on a high-risk indication. So there may be some of your patients that are going to receive 1 to 2 doses before the age of 65. But once your patients turn 65, we need to take a look at each one and ensure that each patient is assessed and given a dose of PPSV23 at age 65 years and older. Now, we have to also ensure that if they received a PPSV23 before the age of 65 years, that we maintain that 5-year interval between the 2 doses as well. We have great handouts that provide detail on this for you if you ever need it. You can go to our website, which is at www.michigan.gov/immunize. Here also is another great handout. This is a great resource that can help you when determining when to give a dose of PCV13 and PPSV23. It does cover vaccine dose recommendations and booster doses for those persons with a high-risk medical indication. We use this handout a lot in our office. It's an excellent handout. It provides all the recommendations that you need to know, and it's on an easy 1-page resource. We would never expect you to remember all the detail when it comes to pneumococcal vaccines. There is a lot of intervals to think about, a lot of risk conditions to think about, so we highly recommend it and encourage the use of a handout such as this, the use of resources such as this. The Handout Pneumococcal Vaccination Recommendations for Children and Adults by Age and or Risk Factor can be found at the Immunization Action Coalition, which is at www.immunize.org. Here is a great handout that can be found at our website. So the website that's listed on this slide, I apologize, is wrong. The website on this slide should say www.michigan.gov/immunize. So this great handout can help you when determining when to give a dose of HIV vaccine based on high-risk medical indications. This handout also contains information on the routine recommended schedule for HIV vaccine. Please remember that for the best protection, it is important to vaccinate based on the recommended immunization schedule for HIV vaccine. There will be times when, based on the risk condition, an additional dose of HIV vaccine may be necessary. I would never expect you to remember all this detail. So utilize a resource such as this, which is the quick look at using Haemophilus influenza type B vaccine. And again, the website on this slide is wrong. Please, if you're looking for this handout, go to www.michigan.gov/immunize, and you're going to want to go under Provider Resources and look under Quick Looks. Now, it is difficult to predict the severity and timing of influenza disease. What we do know is that it remains a serious disease that can be associated with high morbidity and mortality rates. The range of influenza-related deaths annually in the U.S. is 3,000 to 49,000. Our most vulnerable population, which includes persons with medical conditions, put them at increased risk of complications from influenza. Currently, the state of Michigan, so right now, we are seeing widespread influenza activity. And we recently had our first pediatric flu-related death. And we're looking at a couple other cases of child death that could be related to flu as well. So it is important to keep assessing and to keep administering flu vaccine to everyone 6 months of age and older, but especially to our most vulnerable population. Because right now flu is widespread and we are seeing a great deal of people out sick, including myself with a cold right now. So please ensure that you're vaccinating your patients for influenza vaccines. The season is not over yet. Now here is some data on Michigan flu coverage rates for high-risk adults compared to the U.S. As you can see, Michigan did make some positive movement compared to the 2013-14 flu season. For high-risk adults aged 18 through 49 years, Michigan's coverage has been above the national average at 43% compared to 39%. Michigan also saw a 12.8 percentage point increase compared to the 2013-14 season. For high-risk adults aged 18 through 64, Michigan's flu coverage was just below the national estimate, but we also saw an increase of 6.1 percentage points compared to the 2013-14 season. So this is good news, but more work can be done to ensure high-risk adults are vaccinated. If you remember, the easiest way to try and increase vaccine rates is to have a strong provider recommendation and give the vaccine. Here are two types of inactivated influenza vaccine. One is trivalent, which means the vaccine contains 2 A strains and 1 B strain. And the other vaccine is a quadrivalent version. The quadrivalent vaccine contains 1 additional B strain, so an additional amount of coverage. And it also contains 2 A strains and 2 B strains. I did not add on this slide LAIV, which is the live influenza vaccine. because LEIV is not recommended to be received in persons who have a medical indication. So if you have a person who is immunocompromised or who has any type of medical indication, the inactivated influenza vaccines can and should be received. And as you can see on this slide here, they are for persons who are healthy, who have any underlying medical condition, and who are pregnant, who can receive an IIV vaccine. Both of these inactivated flu vaccines can and should be received by someone who has a medical indication. It is important to vaccinate our most vulnerable population against influenza because influenza-related complications are much higher in persons with altered immunocompetence. It is also important to ensure that we are vaccinating close contacts of those at high risk to provide another layer of protection. Now we're going to take a look at a couple of specific medical indications and the vaccines that will be needed. Each of these medical indications can be found on the recommended immunization schedule for adults based on medical indications. The vaccines and the recommendations on when to receive them are all included in the footnotes. The first medical indication we will look at is renal disease. Pneumococcal vaccines are specifically recommended along with flu vaccine and the hepatitis B vaccine. Now, that's not all that we should be looking at. Those are just ones that are, in particular, a person who has renal disease should be receiving. But we should also be assessing for all vaccines. That way we can ensure that the patient is completely up to date and fully protected. So let's not forget about that Tdap vaccine, or take a look to see if they have an MMR in their history or a varicella vaccine in their history, and even a hepatitis A vaccine in their history. Our next medical indication we will look at is asplenia. When a person has functional, which is the absence of a spleen functioning, as you would see in a sickle cell patient, or anatomic asplenia, which is the surgical removal of the spleen or a congenital issue, they are at increased risk for certain bacterial infections. Persons who have asplenia are recommended to receive meningococcal vaccines, pneumococcal vaccines, and a HIV vaccine if they have not previously received a HIV dose before. It's important to know and to remember that we do have intervals to the next dose and that they need to be maintained, and some general rules that need to be maintained for these vaccines as well. I did not put those details on this slide because that is something that I don't want to have anybody get confused with, and it's recommended to actually go back to the footnotes. But for example, when we're looking at our MenACWY vaccines and our pneumococcal vaccines, there are intervals that need to be maintained and vaccines that should be administered first. So please go back to your footnotes and take a look at the schedule to determine what your patient needs and when the vaccine should be given. Now, when we're looking at if this is related to an elective splenectomy, then when it's possible, we should try to give, and the goal is to administer these vaccines at least 2 weeks prior before the spleen is removed. Now, this can't always happen, and you can go ahead and vaccinate after the spleen's been removed, but the goal truly is to try to give it at least 2 weeks prior to when the spleen has been removed. All this information, which is there is a great detail amount of information on this, can be found in the handouts seen in the earlier presentations. So remember that pneumococcal handout from the Immunization Action Coalition, as well as the meningococcal handout from the Immunization Action Coalition, and the recommended immunization schedules for adults. All this information can be found in there. Our last medical indication we are going to cover is hematopoietic cell transplant. We received numerous questions on this medical indication, and it all involves revaccination. In fact, every fall we go out to a certain university and provide at least 3 presentations just on revaccinating the ACT recipients. ACT recipients should be revaccinated regardless of the source of the transplanted stem cells. Most vaccines should be initiated by 6 months post-stem cell transplant unless you're looking at live vaccines. Unlike vaccines received before starting chemotherapy, so chemotherapy is different. Chemotherapy, with those vaccines, we do not need to repeat those vaccines after chemotherapy is completed. And this is because chemotherapy does not negate vaccine-induced immunity. However, revaccination is recommended for people who are recipients of a stem cell transplant, such as a bone marrow transplant. The reason stem cell transplant recipients are recommended to be revaccinated is because the immunity present before the transplant is lost and may not be replaced by the donor cells. So basically, they have a whole new immune system. Now, when revaccinating hematopoietic stem cell transplant recipients, also known as HSCT recipients, all vaccines need to be given because the immune history for that patient is gone. Each recommended vaccine has an interval that needs to be maintained before the first dose can be received post-stem cell transplant. Then subsequent doses in the series need intervals to be maintained. Here I have a few of the vaccines that are recommended and the number of doses necessary to complete the series. So as you can see, an activated influenza vaccine, IV, can be administered at least 6 months after HSCT and annually thereafter. However, there's a little caveat that you can find when you go back to some of the resources that if an HCT recipient is part of a community outbreak, an influenza vaccine can be given at least 4 months after the stem cell transplant. But there are some stipulations and the possibility of a needed second influenza dose. So you always want to make sure you go back to those recommendations. Another vaccine on here is PCV13, where we're going to give this an HCT transplant recipient 3 doses of PCV13, 3 to 6 months post-HCT. And then HIV vaccine, we're going to give 3 doses, 6 to 12 months post-HSCT, and at least 1 month to separate those doses. And then when we're looking at tetanus, diphtheria, and the cellular pertussis vaccines, we're going to start that series 6 months after HSCT. And actually, the vaccine that is preferred is DTaP, and that's a question that comes up a lot. DTaP is preferred because it has a higher antigen amount of D, which is the diphtheria, of the T, which is the tetanus, and P, which is pertussis, compared to Tdap doses. So DTaP is what is preferred for an HSCT recipient, and they will need 3 doses. Now, we do not expect anyone to remember all this. There is a great resource known as the 2013 IDSA Clinical Practice Guideline for Vaccination of the immunocompromised host that is extremely detailed about how to manage any patient with altered immunocompetence. This is the resource to review when vaccinating patients post-stem cell transplant. And I have the website listed here on how to find that document. Our ultimate goal is to ensure that we are providing protection for all our patients through vaccination. If we can vaccinate everyone, then our most vulnerable population will be protected too. We need to keep assessing vaccine need at every patient encounter, strongly recommending and administering the vaccine, along with ensuring the household contacts are vaccinated. Vaccinating a household contact of someone who has altered immunocompetence provides an indirect protection to the patient by providing another layer of protection. Ensure we are not missing opportunities and assessing, recommended, and administering vaccines to all our patients in order to provide the best protection to everyone. Lastly, we have gone over in this presentation a great deal of information. No one expects anyone to remember all the details of the vaccine recommendations, especially when you're looking at the immunocompromised patient and dealing with medical indications. So arm yourself with the best information in order to ensure you are vaccinating your patients, especially your at-risk population. So on this slide here, I have where you can find our handouts, such as the quick looks, which I mentioned when I was talking about the HIV vaccine, and also the direct link to the Immunization Action Coalition, where you can find all those wonderful handouts as well. So then also utilize your local health department, or you can even call or contact the Michigan Department of Health and Human Services, and we're always happy to help walk you through what vaccines may be needed. Other great resources that we have are the Alliance for Immunization in Michigan, the AIM Toolkit, and then the Centers for Disease Control. Here, these next two slides had all the resources that we went to help prepare this presentation for today. So we wanted to ensure that you have those, so you can always refer back to those resources. Here it is continued. And then again, thank you for spending time with us today. This is an extremely important topic, making sure that we're vaccinating our patients who have altered immunocompetence. They are our most at-risk population, and we do want to ensure that they are protected. Again, we covered a lot of information, but one of the best takeaway messages from this presentation is ensuring that we're giving a strong provider recommendation, that we're continually assessing, recommending, and giving the vaccine, and that we know where our resources are so that we can go back to the resources to help guide us on how to vaccinate our patients, especially those who are immunocompromised. Thank you.
Thank you, Heidi. That was an excellent presentation. Chris, can we go ahead and open the lines for any questions that we may have?
Certainly. Ladies and gentlemen, if you have any questions at this time, please press star 1 on your phone. If you have any questions at this time, please press star 1 on your phone. Okay, we have no questions at this time.
Hi, Chris. This is Heidi.
Yes.
If they have any questions at any point, that doesn't have to be during this presentation, they can always email me as well. My email is right on the slide here.
Okay, great.
Okay, thank you for joining us today for this Vaccinating the Immunocompromised webinar. As a reminder, the slides will be available on our Lake Superior Quinn YouTube page within the next week. Also, be sure to join us for a live chat discussing the physician quality reporting system on April 27th. Thank you.
Ladies and gentlemen, that concludes your call. You may all disconnect your lines.